Our topic now is we're going to talk about physician-assisted suicide, euthanasia, and our role, CMDS's role in combating that in Canada. I want to tell you that I personally don't feel that we should have any credibility, or that we would have any credibility talking about physician-assisted suicide if we weren't in some way walking with people who are dealing with terminal illness. In my own case, my schooling in this came with my dad, who at the age of 78 was diagnosed with squamous cell cancer, skin cancer on the side of his head. And because the cancer was localized, it did not metastasize, and he basically died from the effect of that tumor. Surgery was attempted and they couldn't stop the growth, and so he had a very long period of disability at home and then eventually in the hospital. This for my father was very difficult to handle because he was a man of action, a people person, and someone who couldn't stand to be confined to bed. And so I have to say that at several times during his experience, he confided in me and also spoke to his doctors about how if he had the chance, he felt that he would want to end his life. Now, this was, of course, disturbing to me because my father was a tremendous Christian man, and fortunately, I was able to spend time with him. We were able to talk through things. I was able to get him out of the hospital, do all kinds of stuff to try to get his mind off of things. What it came down to in the end is that he said to me, "Larry, it's time for me to go to be with the Lord." I said, "Why is that, Dad?" He said, "Because I don't have anything to give anybody anymore." And that was really an important part of who my father was. I said, "Dad, now it's time for us to give to you." And I said, "Please don't take that joy away from us." And I would tend his wounds. I got to the point where the nurses couldn't do it well enough for me, so I was the one changing the dressings. And as I changed his dressings, I felt as though I was tending to the wounds of Christ. And so this was a very beautiful experience. It was bittersweet. All of you who know who've been through it, it was bittersweet, but it was nevertheless a beautiful experience. Now in my work as a deacon, I'm privileged to be able to go out and spend time with people, visiting them, sick, the shut-in, and especially people at end of life. And I always feel the same way about it. When I come away, I think, what a tremendous honor and blessing to be able to be with people at this most precious time. And the beautiful thing is, Jesus always shows up. So I want to talk about physician-assisted suicide and euthanasia in Canada. I'm just going to give you a brief thumbnail sketch of where we are right now from a legal perspective, because in talking to some of you, there is confusion about where we currently sit. The law of the land is still the criminal code in this matter. It basically says that if you kill anybody, it's illegal and you'll be sentenced. And if you help anyone to commit suicide, you'll also be sentenced. Both those things are still illegal in Canada. There were three big impediments in Canada to the legalization of euthanasia. The first was the Rodriguez case, the Supreme Court case in 1993, a 5-4 decision where the judge said that Sue Rodriguez's human rights were being restricted because of the criminal code, but this was acceptable in a free and democratic society because there was too much of a risk of wrongful death if euthanasia was legalized. That was the thinking in Rodriguez in 1993. The second major impediment was the Canadian Medical Association, your professional association, which said in a series of policies that Canadian physicians should not participate in euthanasia or assisted suicide. The CMA was against it and reaffirmed that at their Calgary meeting last year, and I've read their new policy, which continues to affirm this position. I went to a CMA meeting with my wife. I got in as a doctor's spouse, and I kept my mouth very quiet. They didn't know there was a spy in the room. And they have indicated that roughly 2/3 of doctors in Canada are opposed to legalization of euthanasia. And they've noted that the closer your specialty is to end of life, the more opposed to it you are, which is interesting. So the CMA it continues to be opposed to it, and in April 2010, Parliament defeated a private member's legalization of euthanasia bill by a strong vote of 228 to 59. Now that, I want to remind you, was in April 2010, merely 4 years ago. So what happened in the meantime? Well, the advocates on the other side have been busy. And the Supreme Court of BC judge handed down a decision in June 2012 in the Carter case, which basically said that, according to this judge, physician-assisted suicide should be legal in Canada. That decision eventually went to the BC Court of Appeal, where the decision was overturned by a 2-to-1 decision, and is now going to the Supreme Court of Canada. The decision will be heard by the Supreme Court judges in October of this year. Opening arguments will be commenced. And as you probably know from recent correspondence from us, CMDS, the board, has unanimously decided that we should be there when the Carter case is heard, and that we should represent your interests there by arguing against the legalization of euthanasia and arguing for protection of conscience rights and protection against discrimination for physicians who have conscience problems with participating in this, should the board decide, or should the Supreme Court decide to legalize it. While all this was going on in the courts in Quebec, other activists were very busy there, and a committee, a Dying with Dignity committee, or end-of-life care committee, went out and heard from many people in Quebec, and eventually proposed legislation called Bill 52, which almost passed the Quebec legislature. But at the last minute, the Liberals decided they wanted to take their lunch, and the PQ wanted to work through lunch. The Liberals said, no, we're going to have our lunch, and because of that, they ran out of time, and they weren't able to pass Bill 52. Now, that appeared to me to be the hand of God acting in our favor. However, the new premier, who himself is a neurological surgeon, has indicated that he wants to go ahead with the legislation. And currently what we're doing in Quebec is asking all of our members to write their M&As, because apparently, because of a procedural matter, there has to be unanimous consent for them to go back to the bill at exactly the stage it was at. We're hoping that they don't go back to the bill at the stage it was at and have to go start right from the beginning again, because that will allow us to do more advocacy to try to stop the legislation. So what's driving all of this from a legal perspective? Well, the Supreme Court judge in BC said there was no ethical distinction between physician-assisted suicide and current end-of-life care. Now, we're going to unpack that in a minute, but the second thing is that the court held that between Rodriguez and today's date, a number of jurisdictions have legalized physician-assisted suicide, and when they showed evidence of what was happening in those jurisdictions, they argued that we can safely legalize physician-assisted suicide and minimize the risk of wrongful death. Remember I said that was the key decision in Rodriguez? That the reason they said we weren't going to legalize it was because there was too much danger of wrongful death. Well, the court now is saying, with all the experience we have in the jurisdictions that have legalized it, we now say that we can do it. We can have euthanasia without too much of a risk of wrongful death. We're going to examine both of those suppositions. The first one, the ethical distinction between current end-of-life care and physician-assisted suicide. Well, we know, because we're Christian, and we follow the Ten Commandments, that killing is wrong. And we also know that Christ incorporated the Ten Commandments into his body of teaching. So that's, I'm hoping that you would all say that ethically, there is a distinction between end-of-life care and physician-assisted suicide. Well, guess what? The CMA agrees with you. In their 2007 policy, euthanasia and assisted suicide must be distinguished from the withholding or withdrawal of inappropriate, futile, or unwanted medical treatment, or the provision of compassionate palliative care, even when these practices shorten life. So the CMA is saying, simply not giving someone a treatment, or withholding a treatment, or withdrawing a treatment is not the same as actively causing death. And when you think about it, this makes logical sense. Because if someone is on a respirator and the family decides that, and the doctors, they all decide that there's no benefit in keeping the person on the respirator, And if you remove the respirator and the person doesn't die, you don't then kill them, right? You continue to treat them, right? But if, on the other hand, you decide that if euthanasia is legal and you decide to euthanize the patient, you give them a lethal injection. What do you do if that doesn't work? What if you don't get it in the vein?
Give them another.
Give them another. So there is a logical distinction between the two. Can you all see it? It's funny because the other side thinks that we're not very logical, but I think we are pretty logical, aren't we Christians? It's funny, isn't it? Okay. The second thing is that the courts, up until now, agreed with this distinction too. Justice Sapinka, who was the majority majority judge, wrote the majority decision, said that the distinction drawn here is one based upon intention. In the case of palliative care, the intention is to ease pain, which has the effect of hastening death, while in the case of assisted suicide, the intention is undeniably to cause death. So the CMA agrees there's a distinction. Reason, logic tells us there's a distinction, and the courts tell us there's a distinction. But the judge, in the Carter case, said ethically there was no distinction. Now, as a group of doctors and dentists, medical professionals, you should be concerned when a judge in a court tells you what the ethical standard is for your association. Shouldn't you? Because is this judge a medical practitioner? No. The judge came to this conclusion by bringing in a busload of medical ethicists. And half of the busload said physician-assisted suicide is okay. And half said it's not ethical. So the judge said there's no agreement, so therefore it must be ethical. Now the decision basically said that the Hippocratic Oath was a non-issue because it had been changed before, so it can be changed again. The faith of Canadians was not referred to at all in the decision because it was deemed to be irrelevant. Faith is something outside of the purview of a judge where only reason can be considered. And the religious, ethical, and professional freedom, conscience protection for doctors, nurses, pharmacists, institutions, and other caregivers was not even dealt with in the decision. That's one of the reasons we want to go and do the intervention. The judge's conclusion on the second point, now what I'm into now is the issue of risk of wrongful death. The judge's conclusion was that the risks inherent in permitting physician-assisted death can be identified and very substantially minimized through a carefully designed system imposing stringent limits that are scrupulously monitored and enforced. That all sounds very good, but my wife, who's a doctor like you, said, where are we going to find the money to pay for this in our current healthcare system? Because if a if in order to reduce the risks, you notice the wording is very substantially minimized. Do you notice that? Very substantially minimized. Reduced completely? No. So what does that mean? That means that this judge is putting all of us in this room at risk of wrongful death. And has any politician asked you whether you're prepared to assume that risk? Is this a democracy? These are appointed judges. You see, the reality is that the other side acknowledges that there's a risk. I'm going to show you how much a risk in a minute. I'll show you the studies in Flanders, Belgium. The other side acknowledges that there's a risk, but because they see physician-assisted suicide as a medical procedure, then they assess the risk like they would any other medical procedure. The difference is that they're now saying that taking a human life is a medical procedure. When the lawyers for the federal government said to the judge, even if we put one person at risk, it's too many people, the judge chastised the government lawyer. She said, this is a medical procedure. That's too high a standard. What was the standard we used for capital punishment in Canada when we got rid of it? Do you remember that? One wrongful death meant that we should stop capital punishment completely. When the government lawyer says to the judge, you're putting people at risk, and even if there's one wrongful death, we should not take this risk, the judge says, you're talking about a medical procedure. That's too high a standard. So do you see the problem? This needs to be, in my view, one of our major arguments. Because most people in Canada, when they see Gloria Taylor, they go, oh, poor suffering soul. Even people in our churches will say this. They'll say, oh, poor suffering soul. I don't agree with physician-assisted suicide. But if that poor suffering person needs to have it, you know, I don't want to say no to her. What they don't realize is that when you allow the Gloria Taylors of the world, the Donald Lows of the world to end their lives, then you're basically taking away the criminal sanction. And no government fulfills this standard of oversight, of audit, anywhere in any of the jurisdictions where this is allowed, because there isn't enough money for it. The only oversight that there is in the jurisdictions that permit this is that after the fact, the doctors have to send in paperwork to a central government depository to say that they've done physician-assisted suicide. There's no independent audit. And because you take it out of the criminal code, there's no longer any police force. You see the problem? It's portrayed to us in the media as a liberty issue, individual rights issue. But like every law, it affects all of us. And so what we're assuming by going along with this is the risk that we ourselves will die from a wrongful death, or someone close to us will die from a wrongful death. These are the jurisdictions that currently permit it. And these are the concerns of the physicians and researchers in those jurisdictions where it is permitted. The first concern is difficult to detect a cognitive impairment. So it's very difficult. Even the psychiatrists will say, how do you make the distinction to identify whether someone's competent or not if they're experiencing depression? Is this chronic depression? Is it acute depression? How is it impacting their decision to want to end their life? There's a risk of coercion and undue influence. There were cases in Oregon of doctor shopping, where relatives, encouraged the mother, a daughter encouraged the mother to go to a doctor and to get the lethal prescription to end her life. And the mother goes to the doctor, and the doctor sends the mother for a psychiatric assessment. The psychiatrist comes back, he's met with the mother, he's met with the daughter, and the psychiatrist's conclusion, I think it's more the daughter's idea than it is the mother's idea. Right? How many of you can see these types of things happening in your practice? And so, in that case, you know what the daughter did? She went to the HMO and complained, and the HMO had one of their doctors assess the mother, and guess what? I think it's okay for her to have physician-assisted suicide. No one even considered the conflict of interest for the HMO doctor, right? And so the daughter was able to find 2 more doctors who eventually gave the mother the lethal dose. The mother even then didn't take it. So the daughter said to the mother, I can no longer care for you in my home. Mom, we're going to have to move you to a nursing home. Mom's in the nursing home for a week. Guess what? She decides, time to take the lethal dose. And that was the end of her life. That's from one of the studies in Oregon. There is chronic underreporting by physicians after physician-assisted death. Very interesting statistics that were originally in the June 2012 issue of Focus, which is online. I urge you to read it. Margaret Cottle did a phenomenal job of doing all this research, putting it together for us in a really understandable format. So we are really grateful to Margaret for doing that, and it can be found online. It still is the best resource. The underreporting, 47.2% in Flanders Belgium. Non-compliance with protocols. In almost every jurisdiction there's non-compliance with protocols. The whole issue of fallibility of prognosis. And the other thing that came out of the Flanders Belgium study was that 32% of physician-assisted suicide cases were without the patient's consent. I recently raised this as an issue when I was in a debate with Dying with Dignity and some of the supporters, and they said, those numbers are going down. And they do it with a straight face. So Bill 52, what are some of the issues? I'm going to move along a little quicker here. I don't want to get into the details of Bill 52. You can see all that stuff online. But what they've done is they've said that end-of-life care includes palliative care, continuous palliative sedation, and medical aid in dying. What are the concerns about this? The concern is that once you say that medical aid in dying, or physician-assisted death, is part of palliative care, then if you are a physician who refuses to participate or to consent to participate in this, and you're looking for a job as a palliative care physician, wouldn't the hospital be justified in saying, if you're not prepared to provide the full range of service, then really are you qualified for this position? Because even though they provide conscience clause, they don't guarantee that there will be no discrimination against doctors who refuse to participate. That's an important issue. There is no specific conscience protection in the Quebec legislation for physicians there, and our members there are very worried. They're required, if they're not prepared to participate in physician-assisted suicide, they're required to refer the patient to a functionary, a bureaucrat within the local hospital administration. And the second thing is that there's no conscience protection for facilities in Quebec. So for instance, every hospital, every nursing home has to allow palliative care, has to allow physician-assisted suicide on its premises. The other thing is there's this new category called continuous palliative sedation. This is of real concern because there are no criteria for that. And continuous palliative sedation is normally used in those rare number of circumstances where pain management is not working. But there's evidence to suggest in Holland, and I just want to quickly move to that slide because it's really important. A recent study in Holland has indicated that the regular cases of euthanasia have not gone up dramatically in the last 10 years. It's gone from 2.6% of all deaths to 2.8% of all deaths. But continuous deep sedation has more than doubled in the same time period, which led the editors of The Lancet in an opinion piece to suggest that it would appear that people are being euthanized using continuous deep sedation. And in addition to that, the number of deaths that have increased after intensified alleviation of symptoms has also gone up almost 100% in the same time frame. And the startling statistic, in 42% of these cases, the physician did not discuss the decision with the patient, relatives, or another physician. So, what are the implications for you, and what are the implications for patient care? The implications for you, based upon the regime in Quebec, are that I would be very concerned about conscience protection, because the same groups that are trying to take away your conscience protection for abortion are also trying to take away your conscience protection for physician-assisted suicide. The Royal Society report basically recommended that there be no conscience protection in terms of referral for physician-assisted suicide. In addition to that, we also need to be concerned about patient care for your patients. Because just like my dad, who, if I had not been there, and if euthanasia had been legalized, might have ended up being a statistic, then also for many of your patients, the risk of wrongful death would be there for them. And we need to be concerned about people ending their lives prematurely, because once physician-assisted suicide becomes a medical practice, a medical procedure, then the whole sanctity of life is gone. And what we find in the permissive jurisdictions is that the safeguards are not followed, and in reality they no longer exist. So how can we respond? Well, we have a video that was developed last year, The Gift. It's on our website. We are encouraging, we really need members to publicize these materials. We have a PowerPoint presentation, handouts, everything you need to do a presentation at your church, you can do. We need to get the word out to Christians that this is not just an issue of individual liberty, this is an issue that affects all of us and the whole way that life is valued in our society. We need people to write the Minister of Justice, Peter MacKay, to continue the Conservatives' stand of being opposed to this. We need to participate in the CMA consultation. We need to keep connected with CMDS Canada via social media. If you like us on Facebook, then we can continue to send you updates on this. If you're a student, you need to organize a presentation at school. And if you haven't already done so, if you could help us financially to support our challenge, our legal challenge, that would be wonderful. These are all the ways that you can assist in getting the message out. There's no way that we, myself, the staff, the board, can do this on our own. We need all of the members to mobilize in any way that you can to get the word out about this. Diane? Diane is just going to talk briefly about her experience of what it was like doing a presentation at her church. Diane did a presentation and was able to talk to members of her church about this issue, and I just thought it'd be neat to have her talk about how that's affected her.
So one of the statistics that Larry didn't mention is that in a study, and I forget which jurisdiction or which state it was found that 32% of evangelical Christians would vote in favor of euthanasia, not knowing the implications of it. We were out for dinner with a friend of ours, and his family hails from the Netherlands, and we got talking about it, and I asked him, well, what do you think about euthanasia? And he says, oh, yeah, no, I could see myself using euthanasia if the time came. And I looked at him and I said, well, what if you were to go to a nursing home to see your parent, and your parent were not there when you got there? And that has happened in different places. People do not realize the implications of euthanasia, and unless we tell them, they're not going to. And I think it's just so important to make our church family aware of what that would mean. If there comes a time for a referendum, how are evangelical Christians in Canada going to vote about something like this? I actually took this from Margaret Cottle, because last year when she spoke, she says, we have to be telling our churches, and it just really resonated with me, and I went home and struggled with it, because I don't really like to speak in front of people, and sat down and put together a presentation, and our church actually helped facilitate that. We had a culture night, and someone spoke about the issues with birth control and abortion, and I spoke about euthanasia. At the end of the evening, the pastor was shooing us out the door because people had so many questions and they just didn't want to stop talking about it. I have a slide presentation that I'm very happy to share with any of you. I have notes that go with it, and they're my own personalized notes with incidences from my own practice that I put into the slideshow. But if anybody would like to speak about this to their church, I would just really encourage you. It turned out to be a very good experience for me. And we have the resources. We can make it as easy for you as possible.
It's not really just my issue, it's our issue, and there's so many of you who have been involved every place, and Larry's being modest. He's worked very hard on this, and many of you here in the room have been very supportive and have prayed and have done those things and care about this very deeply. I think it's what Diane said to you is really important. Think of stories from your own practice where people have said, oh, don't work too hard on dad, or, some of these things like that, where you can see greedy relatives and other things like that, people who are vulnerable, who are not being protected, and tell your own stories from your practice. After the Carter case, I was on CBC on Nancy Wilson's program, and Joe Arve, who's the lawyer for the other side, is in a wheelchair, and he was very articulate. And finally, I just said, I'm not a lawyer. I don't know about all these things, but I can tell you from 25 years of sitting at the bedside of dying patients and caring for them and their families that this is a really bad idea because they're very vulnerable. And that resonated with people. People do still want to believe us. So you have something to say. And it is a little scary, but, everything in life that's worth anything is kind of scary to go out there and do those things. And people say, well, it's already happening, and it is happening in our nursing homes. But if we take away the biggest protection we have of it being illegal, how is that supposed to make it easier for this to be taken care of?